All right. Thank you again for having me. I'm going to be talking about posterior medial rotatory instability, and it's really just one of the areas of a mechanism that's part of really complex elbow instability. And for that reason, I'm going to talk a little bit about an overview of that, and then obviously it'll carry through with some of the other talks today. This is something that I really enjoy. Although they're complicated, it's something that's really changed in terms of our treatment over the last, probably 10 to 15 years, that we understand how to take care of it a lot better. When I was a resident, I think around 2003 or 4, Jesse Jupiter published a paper on terrible triad injuries, and the results were pretty dismal. But that paper started a process of people understanding how that injury needed to be fixed, and since then, it's progressed. And one of the fortunate things is if you follow mechanistically what to do in a pattern in terms of fixing these problems, the patients generally do pretty well now. So the talk today is going to include the elbow stabilizers, the anatomy and biomechanics, and I mentioned that a little bit earlier in my previous talk, but I'll have a lot better details of it this time. And then I'm going to only speak on the pattern injury for posterior medial rotatory instability. There are a couple other patterns, and they're going to be talked about by other folks today. And then I'll go over the treatment algorithm that I generally follow for this, and essentially I'll tell you how I do it in terms of a PMRI injury as opposed to overall. So first thing, in case anyone doesn't understand this part of it, so first thing you need to do is understand and define complex elbow instability. And a simple injury means, a simple elbow instability is basically they have a dislocation that's all soft tissue. A complex elbow instability injury is one that has bony injury and soft tissue injury with the dislocation. So that's the easiest way to just kind of keep it in your head. This is one way you can organize it in terms of sorting things out based on if it's anterior, posterior, lateral, or medial, but that doesn't really help you in terms of knowing what structures are the most important structures to address when you're taking care of any of these difficult problems. And this is where we'll get into that Mayo model that I showed in that last talk. And this is originally, they probably stole that fortress idea from this. This is Jamestown. This was the first successful settlement in the United States. And you can see the 3 turrets. And this was basically where people lived when they were trying to avoid being attacked in the 1600s, living in America. But fitting in with that, the Mayo Group and Sean O'Driscoll came up with this model, and the 3 turrets here, just like the Jamestown fortress, include the ulnar humeral articulation, the lateral ulnar collateral ligament specifically, but the LCL, and the MCL, or the anterior medial collateral ligament. And you can even see that the ulnar humeral part is bigger than the other 2 parts, and so it's really the most important primary stabilizer for the elbow. I mean, you always have to address that bony-wise, no matter what's going on. The secondary stabilizers include the radiocapitellar joint again, and the common flexor and extensor mass, as well as the capsule. So going into a little bit of the biomechanics for the ulnar humeral joint, it's the keystone for the elbow. Everything is about this. So when you're trying to figure out how to fix things, okay. If you're worried about trying to fix these things, this is what you always need to fix first, no matter what, and that means the olecranon and the coronoid. It's the primary stabilizer to the elbow, and it depends on what's going to happen in terms of instability based on the pull of things. So the coronoid prevents the elbow, the ulna, from sliding posterior, while the olecranon prevents it from sliding anterior. And Mori and Ahn did a lot of these basic science studies, and a number of them are getting repeated again by Graham King, and part of it's just technically Graham's been able to come up with a more scientific way to approach it, but interestingly, a lot of the results are similar. But the original paper that the Mayo folks put out was that essentially you could remove 50% of the olecranon with still adequate stability of the elbow. And that's what this chart's essentially showing you. The other thing to keep in mind is when you go into flexion, there's a posterior vector driving it out the front, and so that's the importance of why you need your coronoid. And then when you go into extension, your triceps is actually driving it anteriorly, and that's what you need your olecranon for. So this again illustrates the importance of the coronoid, and so the graph up top, essentially you're seeing the effect that the coronoid has when you take out 50% and 100%. But the radial head's also important, and that's demonstrated by the second graph below in terms of how much you see the instability shift with both the radial head gone and the coronoid gone. So 50%'s here, pretty similar with a radial head or no radial head, so it tells you the importance of the ulnar humeral joint. But in larger losses of the ulna, the radial head becomes a really important secondary stabilizer. This is a picture of, this is the device that Graham King has in terms of doing things, and part of why this is pretty nice is because what you can see is the arm, they leave the muscles in the arm, and then they suture, they basically suture each of the muscles, and these go to these actuators. So they leave the arm as close to native as possible when they're doing a lot of these tests. One of the other things they can do, which is pretty interesting, and you see in one of their tests, is they can adjust the arm either from a dependent position, which is with your elbow at your side, or they can abduct it into a varus position or a valgus position to help basically demonstrate positions that are more related to daily activities, such as getting some milk out of a refrigerator or throwing. One of the studies that I found interesting, though, when they did this was one of the early first studies they did was they looked at type 1, type 2, type 3 coronoid fractures based on Regan-Morey. And I'll show you some pictures of that in a second, but to simply refresh, a type 1 is a tip injury. A type 2 is anything else up to 50%, and then a type 3 is more than 50%. And essentially what they showed in the kinematics for a complex elbow injury, that fixing a type 1 tip injury, whether it's either suturing down the capsule or somehow reattaching it, doesn't make any difference in terms of your stability, in terms of fixing folks' elbows. So generally, I don't do that anymore in terms of tip injuries. Now, they're not that common either. A lot of times, there's much bigger coronoid fractures that you do need to address. The other things to keep in mind is, well, so how do you figure out what the height of the coronoid is just looking at the x-rays? And so one of the basic rules of thumb is, first of all, the coronoid makes an angle with the olecranon of about 30 degrees. But what is more helpful is if you compare it, the height of it in relation to the olecranon in the back, when you get down to the coronoid, if there's a fracture and it's matching the tip of the olecranon, then you have 50% bone loss. So that kind of completes our ulnar humeral joint. So now we'll talk about the other two stabilizers, one being the lateral collateral ligament and the medial collateral ligament. And one of the things I talk to our residents about all the time is, the MCL gets all the publicity because it's the sexy one, and the only reason why it's the sexy ligament is because there's professional throwers. Because the truth of the matter is, for the rest of the world, throwing really doesn't matter that much. And as my chair used to like to say, your elbow and shoulder is designed for throwing an occasional spear or rock. It's not really meant to throw a baseball at 100 miles an hour. So the LCL is what's important. And the reason why the LCL is important is because every time you reach your arm out, it's in a position that's going to cause a varus stress on it. And so this always has to get fixed. And it's really far more important than the MCL in terms of the stabilizer of the elbow. And there's the three main parts of it. There's the annular ligament, the radiocollateral ligament, and the lateral ulnar collateral ligament. On the MCL side, there's three parts. There's the anterior band, the posterior oblique band, and the transverse band. And this is sort of like the ACL. People study this ligament all the time because there's throwers. And so the other thing that's nicely characterized about it is the anterior band, which is the one we reconstruct for throwers, that's taut in 0 to 60 degrees, versus the posterior band is taut in 60 to 120 degrees. And there's been some more recent studies looked at it very specifically. It's at 90 degrees where it's maximally taut. And that's additionally, keeping that in mind, why, if you have a stiff elbow and you're trying to release them, one of the first basic things you do is you cut out the PCL. or the MCL, because it actually will help with your flexion pretty simply. Another area, though, in terms of stabilizers is the radiocapitellar joint, and we talk a lot about that. And from a valgus point of view, the MCL is not valgus. From a valgus point of view, the MCL is much more important. But the radial head is also important from a loading point of view, but not as much from a valgus point of view. And that's essentially what Maureen Ahn showed in this study here, that you can see the difference between the two heights based on the order of how they either cut out the radial head or cut the MCL in what order. And you can see on A, the difference between the two is a lot larger than the difference in B. And basically, it just shows you that the MCL is a much more important contributor to valgus stability than the radial head is. And then finally, the last little part is there's muscles crossing the elbow that provide compressive force. And I mentioned that yesterday when we were talking a little bit about when you see a sag sign with the fluoroscopy, is that, you know, you're not actively seeing those flexor and extensor muscles contracting to stabilize the elbow. So I'm just going to kind of run through real quick in terms of the bony patterns, because you kind of have to understand this really for the rest of the lectures in this part. So this is the Regan-Mori classification. I mentioned this, type 1, type 2, type 3, in terms of coronoid fractures. But this classification by Driscoll is what we kind of follow now a lot more. And for the longest time, I found it confusing, but now I kind of understand a little bit better. And essentially, a type 1 is a type 1 like a Regan-Mori, and a type 3 is basically the same as a type 3 and a Regan-Mori. But the O'Driscoll classifications just added all these type 2 injuries that are 50% with these anterior medial injuries, subtypes 1, 2, and 3. And so when people do biomechanical studies, they study it based on these different areas being fractured and what happens. Radial head fractures, this got discussed a little bit yesterday, but there's type 1, 2, and 3, you know, non-displaced, minimally displaced, completely displaced. And this is important to discuss and understand in terms of what you're doing if you're talking about posterior lateral rotatory instability. And then you combine all that now with the primary stabilizers and which ones do you need to fix to get your elbow stability again. And that's going to depend on which ones are injured based on the pattern of injury. And this is generally 4 main patterns that you'll see. One is posterior lateral rotatory instability, which includes terrible triads, because that's what a terrible triad is. PMRI, which is much less common. About a pure valgus loading injury, which is basically just the arm being wrenched out. And then transolecranon fracture dislocations, and they're a little bit of a different animal, because they tend to be more like a pilon with an ankle, where it's mostly a bony injury and most of the ligaments are intact, attached to bone still. So I'm just focusing on the posterior medial rotatory instability. And so the mechanism of injury is usually an axial load during flexion. And essentially, you see a varus force on the elbow that affects the anterior trochlea and coronoid. And a physical exam test you can do on these folks, if they're not hurting enough in clinic, is essentially this test. It's almost an ADL test, but they call it the gravity-assisted varus test. And if they have, basically, they're going to have significant pain and complaints of instability of their elbow if they hold their arm up and they move it from a position of flexion to extension, or from extension into flexion. So what's the injury pattern? Well, we've looked at PLRI for a long time, and so we know what that is, but what's PMRI? And PMRI is similarly three characteristic things. One is the posterior elbow dislocation. 2, it's the lateral collateral ligament injury. And then 3, it's the coronoid fracture. And classically, from the biomechanics studies, they'll tell you that the posterior MCL is injured while the anterior MCL is not injured. And so, but we don't really know that for sure because we don't have a way to look at all these patients that are getting injured. So I would not be so specific. But many times when you look at this injury, it's hard to figure out. And so one of the things, again, I usually point out is it's not always sometimes what you see, but it's what you don't see is what will help you in terms of being suspicious about this injury. And that is essentially no radial head fracture. These patients don't have a radial head fracture. And if you think about the mechanism, that's right, because they're having a varus load on their elbow, not a valgus load. And so if you see some kind of coronoid fracture and they have no radial head injury, then you need to keep this in the back of your head, that this is a significant problem. And usually that, in my mind, sets off an idea that I'm going to get a CAT scan to look at that coronoid to see exactly what's going on with it. Because it's very difficult to be able to characterize a coronoid injury just looking at plain x-rays. So that's one of my take-home points is, remember, if you see a coronoid fracture with no radial head fracture, you got to be suspicious and concerned that there's a PMRI injury. We talked about this a little bit earlier about the different classifications. This is also important to understand in terms of why this happens, and that is understanding the anatomy of the medial coronoid and why it fractures the way it does. And Dornberg and Ring did a lot of CT studies with this, which has been really helpful in terms of understanding it. And essentially what you see here is there's a large portion of the medial coronoid that's not supported by the ulnar shaft. And so when you have that varus load on the elbow, it's just going to shear right off. It's not supported axially in that way. And that's exactly what happens. But you can see here again, looking at that, the anterior medial coronoid from that view, it again isn't supported by the ulnar shaft. And you can again see it here both on this cadaveric picture too, in terms of unsupported medial coronoid. And you can see why then a varus load is going to fracture that. And essentially what they measured out is a little over 50% of your coronoid is unsupported by your ulnar shaft. So then we know what the mechanism is, and we then also then have to figure out how we fix this. And fixing it's, I think, fairly straightforward, but some of the other questions that are being more looked at lately have to do with, what about when you have a really small coronoid fracture? How big does a coronoid fracture for a medial coronoid have to be that you need to fix it? And then there's also a bunch of focus on the posterior medial collateral ligament and, when do you have to fix that, or in terms of all these issues. And I'll get into that a little bit. But the conclusions of this study, which basically they created a PMRI injury, the main conclusions you can take out of it is, one, in a dependent position with the forearm supinated, a torn LCL and all type 2 anterior medial facet fractures, the elbow is stable. And so that doesn't mean you don't fix it. What it means and what it helps support is the idea of therapy and being able to do therapy with what we call a supine elbow protocol, which means usually all my patients that have complex elbow injuries, independent of what it is, they get started on therapy almost within a week of having their elbow fixed. And what they do is they come in and see our therapists. They have a splint made to support, a long arm posterior splint to support their elbow, but they learn how to do the exercises laying on their back when they're essentially raising their arms straight up above them. And by doing that, the ulna is actually not seeing the stress on the ligaments and it's staying reduced. When you're in a dependent position and you have these injuries, and if you have some inhibition of your flexor and extensor masses, you're going to tend to have sag, and you're going to reproduce some of the instability of the sag sign that you see in the OR. But in terms of fixing things, one, if you have just a type 1, which is very small, you can just repair the LCL and they should have adequate stability. But anything else bigger than that, you need to fix essentially the coronoid to maintain the stability. The one thing fitting back with that another study it's actually not even published yet, but it's a study by Michael Hausman from Sinai, and they're looking at posterior medial collateral, and I didn't really include this, is he has a big focus on the posterior portion of it. And one of the things that was helpful in terms of what he said was that sometimes you have these coronoid fractures that are super comminuted and you can't fix them. So what do you do? And at least biomechanically, they were able to show that if you fix that posterior medial collateral ligament, it will stabilize the elbow enough. And so that's something to keep in mind in terms of some of these really bad coronoid fractures that you can't fix. So these are what I call my elbow repair rules for dummies. And so this is what I generally follow no matter what. And history for me has been when I don't follow these, that's when I usually have problems. And so I try to just stick to these no matter what in terms of how we approach things. But when I think about fixing it, no matter what the injury is, I generally repair posterior first, then lateral, then medial. Now, it doesn't mean the incisions are there. It just means the way I think about what's the most important thing to fix. And so, you know, you fix the ulna, the olecranon first. And then essentially you want to fix the indicated fractures first because, as I said, the bony stuff is really the most important. And then secondarily, you're going to fix the ligaments that you need to further stabilize the elbow. So first is repair the ulnohumeral joint. That's posterior. So you got to reduce the joint. And although this is not a PMRI injury, you want to plate it. So you've done step one. You basically helped reconstruct the ulnohumeral joint. Step two is going posterior. Now you're going lateral. You want to repair the lateral structures. Now, if you have a PLRI injury, then you address the radial head first. But in this case, you don't have a radial head injury because we said there's not a radial head injury for this mechanism. And so then basically what you have to do is you need to fix the LCL. And that seems very straightforward to think about it because essentially it's a varus stress on the elbow and it's going to be torn every single time. So when you're treating these acutely, there's always plenty of tissue there to repair them. And then fortunately, this injury typically is almost always an avulsion injury off the humerus. So you essentially can just take some suture, run it in a locking manner, and then pass it through bone tunnels in this way. And I generally always use bone tunnels, and I don't like using anchors. Some of my partners use anchors, and the reasoning is if you ever get an infection in an elbow, it's very hard to get that anchor out. And then the other part is that you can always come back and use your bone tunnels later after you've washed that elbow out, which is why I stick to that premise all the time. Step three is repair the anterior structures, and when I mean the anterior structures, we're talking about the coronoid. So you got to fix, as we mentioned, any type 2 or 3 subtype coronoids you have to fix. Just in the same way, if you're not talking about anterior medial injuries, pretty much any type 2 or type 3 Regan-Mori coronoid fractures you should be fixing as well. And then last is fixing soft tissue immediately if you need to, and that's where bringing in what I mentioned earlier is that new study that's 2017. It's an article in press right now in JSCS. Now, if you do all that, even with PMRI or PLRI, and you still have a problem, then basically you can put on some kind of hinge joint stabilizer, and typically this meant a hinged X fix. But there is another option that I'll show you in just a second. But folks that you need to do this for are people with gross elbow instability. If you're worried about your fixation, sometimes those coronoid fractures aren't really that held together very well, and so if you put a joint stabilizer on them, you can protect them for 4 to 6 weeks. If you have delayed treatment, even though I'll tell you that delayed treatment is very difficult in these kinds of injuries to get to work well, or you need prolonged mobilization, or for a big elbow reconstruction, which would be doing like interposition arthroplasty. But this is a newer implant, which is kind of nice to use. It's called the IJS. It's an internal joint stabilizer. And what it does is essentially that pin goes down the center of rotation of the ulna through the lateral side. And then this other plate screws on the back of the ulna. And it essentially accomplishes the same thing in terms of a hinged X fix. So it's useful in terms of a patient, in terms of protecting them, but you don't have all those pins sticking out of the patient, because invariably with that, you'll get a lot of phone calls about your pin sites and things like that once they start moving, and this avoids that. Now on the flip side, you have to go back and take it out, but it's still pretty helpful for that reason. So in conclusion, in terms of PMRI and across the board with PLRI, really all of these complex elbows, it's important to understand the anatomy and the biomechanical foundation that will help you understand in terms of what you should be fixing. And you don't want to miss PMRI, and the way to always be worried about it is when you see a bad complex elbow that doesn't have a radial head fracture. The ulnohumeral joint is the most important thing to fix, and so you always have to address that, and that means the olecranon as well as the coronoid. And almost every time you're going to have to fix the LCL because of what I mentioned about it's so important for your ADL activities with shoulder abduction. And then again, don't forget the coronoid. Thank you.